Okay, let's quickly review the anatomy of your eyes. Okay, so here's your eye. We have the pupils in the middle, then surrounded by the iris, which is reflecting the color of your eye, and the white part is the sclera. Now, you the punctum, or also called the caruncle, and the inner canthus is where you can find the lacrimal canal, which is connected to the lacrimal duct, which drains into your nasal cavity and then into your mouth. Yes.
Of that procedure where they change the eye color, they inject some type of dye in there. That's kind of crazy, right?
Well, it's important to some people, so I'll let it be. They have
Well, I mean,
money. They
yeah,
have 10 grand, so yeah, go
10
ahead.
grand
Yeah. I think it's actually 12,000.
just to do both eyes. Oh,
Yeah.
it's still new. I wouldn't. It's just crazy.
Well, you're already married, so what are you changing
Yeah.
your eye color for? Who are you trying to impress?
I think it's crazy that anyone would even mess with their vision.
Well,
Like it's
again, if somebody's still looking for,
look good.
their eternal mate or their next ex-wife or their
Oh,
next
yeah.
ex-husband, then yeah, okay. All right, so here's the anatomy of the inner eye. So we saw the outside. So here's the eyeball. So it has several layers. So starting with the sclera, and then we have the lens, of course, which is transparent. It's covering the eyeball. Then inside we have the optic nerves, and then we have the retina, which is the yellow layer. It's not really yellow, but let's just label it for purposes of identifying them. And then we have the macular area, which is the very central part of the back of your eye, the very central part of your retina, which is responsible for central vision. So what happens is the eye reflects light. So we can't see, right, unless there is light. Yeah. So as light enters the eye, so it's reflected against the retina, and then whatever image is reflected there, that will be interpreted by our brain, and then we can see our surroundings. Okay. All right, let's go straight to the disorders now. Oh, by the way, the eyeball is filled with a clear fluid, so which gives the eyeball its shape. That fluid is called aqueous humor. It is constantly produced and drained. So the as our eye produces aqueous humor, which is again a clear liquid, it drains in these canals right here. So fluid will come out through here and then drains out to the sides. Here you have the canals here, canal of Schlem. And then you have open angles here in both the upper and lower parts of the eyeball. And that is where fluid will drain. And then again, everything drains down into your nasal cavity. Okay, and then down into your GI tract.
A lot of people with the LASIK surgeries been having issues with like dry eyes. A friend of mine had it done. Now he's wearing glasses again. Don't ask me why, but his vision's not the same.
Okay.
Surgery's not worth it.
Depends on which surgeon, did it. Because let's say my my wife has a cousin in North Carolina, and that's That's all he does. You know, he's
Okay.
yeah,
he's
he's a ophthalmologist and he does LASIK for a living. So yeah, he has repeat customers, you know, word of mouth. So he does well for himself. Right. Since some of our eye disorders require eye drops, especially glaucoma, for instance, which requires lifelong eye drop administration. So let's review how to administer eye drops. So here are a few facts. That's why it will make sense that in our skills checklist, when we administer eye drops, it's only given on the lower conjunctival sac, and we only apply one drop at a time. Okay, only one drop at a time. We have to wait 1 to 2 minutes before administering a second drop of the medication. Okay, so here's the reason for the waiting of the time, the time, you know, the time gap, the interval. The conjunctival sac can only hold 50 microliters. Now, the average volume of one drop, considering that, given that you administer it from an eye drop bottle, okay, not, of course, this will not apply if you're administering something else, but all eye drop bottles are measured already by the engineers, okay, that designed the container to administer between 20 to 35 microliters. So if you administer 2 drops consecutively, can the lower conjunctival sac hold that medication? No, because it will, yeah, go beyond 50 microliters. Okay, so again, the lower conjunctival sac only has capacity for approximately 50 microliters, and the average drop from an eye medication is about 20 to 35. So that's why we have to wait. Okay. Because otherwise, if you give both drops at the same time, where will the medication go? Well, you're just wasting it. It will just go right down the patient's cheeks. Okay. We also have corneal membrane barriers. So it really doesn't make sense that you administer the medication on the lens, okay, on the cornea, because it cannot absorb anything. Okay, so that's why where do we give the medication? On the lower conjunctival sac, where the blood vessels are, which can absorb the medication. Again, the corneal membrane doesn't permit anything. So this protects the eyeball basically from trauma. So if you get dust, hair, or other insects or whatever, let's say somebody pokes your eye. So this is a protection, right? Which limits absorption. So we don't administer medications there. And then we have the blood ocular barriers, of course. These are again protection. These are natural protections in our eye, okay, to limit infections, okay, or other debris from entering the eyeball. Plus, finally, we have these automatic reflexes. Okay, so whenever we have anything entering the eye, whether it's dust or dryness, for instance, or cold air, or including medications. So when you administer medications, what will you automatically produce? Tears. Okay, so the patient will automatically have increased tear production whenever you put anything into the eye. So that's another reason why we do not give more than one drop at a time, because our tears will just wash it away. Okay, and then we will automatically blink. That's a reflex. And then finally, there's drainage as well. So drainage is example when you wake up in the morning, especially if you're laying down on one side, what do you find in the corner of your eyes? Some crust, right? Some white, yellowish, dry crust. Okay, so these are all from the drainage. So your eyes are trying to wash away any pollutants. Okay? And then they gather, of course, in the inner or outer canthus. Okay. We'll get to the medications that are specific to the eye disorder. I will get to them later on the next few pages. Let's go to cataract. Well, glaucoma's here first, so let's do this first. Glaucoma. This is a chronic disorder. So this is a disease characterized by increased intraocular pressure. The ocular pressure is anywhere between 0 to 15. Okay. Here's the chart for administering eye medications. This could be a drag and drop question on your final exam. I mean, it's self-explanatory, and I hope you at least administered an eye drop. Have you done this in clinical nursing home?
We weren't able, we didn't get that exposure, Professor.
Okay, so here, if you read it, very important is patient has to, of course, be laying either flat or at least semi-fowlers, right? And then they have to look up, and you can raise the eyelid, have the patient look up a stationary object in the ceiling, and then whatever you do, do not contaminate the tip of the bottle. Okay. Don't touch it on the patient's eyelid, eyelash, anything, okay, or your fingers, okay, never contaminate it. If it's an ointment, then this is how you administer an ointment, okay. The difference, of course, between ointment and the eye drop is, what do you do after administering an eye drop? Where do you apply pressure?
Is it?
In the inner canthus, right? Okay, so for how long?
30 seconds.
About 10 to 30 seconds, right? Okay, apply pressure here. What are we doing? Why are we applying pressure? To prevent what? Okay, medication from entering the lacrimal duct. Okay, so because we don't want the medication entering the patient's nasal cavity and then getting absorbed, systemically, right? Although there will be systemic absorption to some extent, but that's the reason. Now, for the ointment, of course, it's that action is not necessary, because the ointment, will it run down anywhere? No, it's based on wax, right? It has petroleum in it, or glycerin, so therefore it will stay wherever you apply it. So there's no need to apply.
When you put the petroleum, won't that obscure your vision, right? Won't it get like hazy, like?
Yes, of course. Yeah, because it's an ointment, so once you blink, then it will spread throughout the eyeball. Now, of course, anything excess you don't put back. Okay, if it runs down out of your eye, just gently wipe it off. Okay? But what you don't do is rub the eye.
Or go driving after
Right.
that.
Right, correct. So if you're giving, let's clarify the period here. You see here, if the patient receives an eye drop, how long do we again put pressure? Actually, it's actually 1 to 2 minutes. Okay, it's 1 to 2 minutes, so more than a few seconds. And then if the patient needs 2 drops of the same medication, we will wait 5 minutes between administration. If you're giving more than one type of medication, then you should wait 10 minutes if it's a different medication, if it's a different eye drop. Does that make sense? Okay, because for example, especially glaucoma patients will have 2 or 3 different eye drops. Are we clear? So if it's, let's say, 2 drops of the same medication, how long do you wait? 2 drops of the same medication. How long? 5 minutes. You're giving multiple eye drops. 10 minutes between each medication. And then 5 minutes between drops of the same medication. All right, so glaucoma is actually very common. Most patients are elderly, but doesn't mean we don't have young people who have glaucoma. We do have children as young as 6 or 7 that are diagnosed with glaucoma. Now, the earlier we diagnose, then the better, because the disorder is going to cause blindness because of increased IOP. Let's look at the reasons next. So how exactly does the pressure arise? Now, there are two problems in glaucoma, one of two, or some patients are unfortunately have both problems. So the first problem is, remember the aqueous humor, the liquid, the colorless liquid that we produce in the eyeball? Okay. So that's supposed to do what? Supposed to drain, right? Supposed to be constantly produced and constantly drains, like a river. Supposed to be like a river. The problem in glaucoma is the patients have, remember the angles we looked at earlier? Let me go take you back there. 1910. Yeah, remember these canals here, right? To which the aqueous humor will drain. So some patients will have narrowing of these canals, impeding the drainage of aqueous humor. Some of them will have swelling, for instance, which will again close the canal. These drainage holes, these drainage passageways will be blocked. Okay, so these, as you can see, there's angles, right? So these angles are what we talk about here in glaucoma. So one of two problems can occur. Okay, so there's either a narrowing of that canal or there's some mechanical obstruction that will decrease the drainage of aqueous humor. Another problem is some patients will have increased production of aqueous humor. So, so since that's the problem, either they have an increase in aqueous humor production or there's a decrease in aqueous humor drainage. So what will happen to intraocular pressure if one of the two or both occur?
It could go up.
The IOP pressure, the intraocular pressure will rise. And when it rises, of course, it will cause pressure against the retina and the optic nerve and then cause permanent damage. Patient will lose vision. Okay. Risk factors who can get glaucoma. One is, of course, heredity. Okay. Black or Asian race, heart disease, diabetes is very common. Or history, again, it comes in the family. Migraine syndromes, myopia, older age, okay, or thin cornea, or trauma, or let's say use of steroids. They can all lead to glaucoma.
Sir,
Yes.
I use steroid nose spray. I mean, I'm sure it gets into the whole area. So you don't think that's good then?
Well, it doesn't really specify.
I use Flonase every day, so I don't know.
Yeah,
It's just
I don't
my
know if,
knowledge.
because it says here prolonged use of topical or systemic corticosteroids.
Oh,
So yeah, I would say, yeah, it will predispose you to glaucoma.
okay.
Oh, sorry, I confused intracranial pressure with intraocular pressure. Sorry. Intracranial pressure is 0 to 15. Intraocular pressure is 10 and 21, between 10 and 21. Are we clear? All right. So any increase, so once your pressure IOP reaches 22 or higher, then you will be diagnosed with glaucoma. Intraocular pressure measurements is part of any eye exam. So if you're wearing glasses and it is a prescription glasses and you see an optometrist, part of your annual exam will be measurement of your IOP. Okay. They do this routinely because glaucoma is called a silent thief The patient has no symptoms, no eye pain, nothing. The patient will just gradually lose peripheral vision, and then eventually it'll be like a curtain closing. So it starts with peripheral vision loss, and then the vision goes narrower and narrower, and then the patient goes blind, okay, over several years. So here's the pathophysiology again. The patient has a increase in intraocular pressure caused either by increased production of aqueous humor and or decreased drainage of the aqueous humor. There are many types of glaucoma. We've got wide and acute or narrow angle glaucoma. And then there's also acute angle closure glaucoma, which is an emergency. As I said, glaucoma is called a silent thief because it robs you of your vision, okay, over several years. No symptoms early on. The patient just goes blind slowly over several years. So the patient eventually, as the vision loss increases and becomes more evident, noticeable, the patient will experience blurred vision or halos around lights, difficulty focusing, no, they can't see in low light, and then again, loss of peripheral vision. And then finally, patient will have, if the IOP pressure is significantly high, then they'll have some eye discomfort and even a headache. So here's a illustration of the closure of the angles. So here are blockages of the passageway of your aqueous humor. And here are manifestations for each type. Table 58-4, please read on your own. So we've got wide angle, narrow angle, acute angle closure. As I mentioned earlier, this is the one that is an emergency. This one will require emergency surgery in order to prevent permanent blindness. Okay. So acute angle closure, these are your manifestations. So the vision loss is rapid. Patient will have periocular pain. So at least this will be alarming to the patient because suddenly they have eye pain. Okay. And then plus there's nausea, vomiting. The cause of the eye pain here is a sudden rise in the intraocular pressure, which is good and bad. Good that the patient will, of course, go to a doctor because of the symptom of pain. Bad news is they may not save the vision. Okay. Because let's say they don't go to the doctor. Okay, then just continue to rub their eye, for instance, or lay down in bed, not knowing that it is a emergency, okay, and that not knowing that they could go blind if they don't receive proper treatment. Let's go straight to the management. Now, the management is mostly medications. Majority of patients with glaucoma will be on eye drops forever, for life. Okay. Now, the medications, of course, will be multiple. There will be a combination of drugs that will, what were the two problems again with glaucoma? There is increased aqueous humor production or a decrease in the aqueous humor drainage. Okay, so one or two. So therefore, when those one or two are present, it will increase intraocular pressure, damaging the retina and then the optic nerve. So the only way to relieve the pressure is to do what? Give them eye drops to decrease the production of aqueous humor, or give them eye drops that will increase the drainage of aqueous humor. Okay, so most patients will receive both medications.
How long do they stay on the drops?
Forever.
Forever? Oh, wow.
Oh, how long do you want to keep your vision?
Bro.
Okay, so you take these eye drops forever. All right, so just like with seizures, so these are there's really not much we can do here. There are surgeries that are there are surgical options offered, but not all patients have that option, or some patients are not good candidates for eye surgery, especially if they're diabetic, for instance, and very high risk patients. So if the surgery is not an option, then the patient will be on eye drops forever. So we've got cholinergics, pilocarpine. So this will increase aqueous humor flow or drainage. And these are your side effects. Beta blockers decreases aqueous humor production. And these are your side effects and nursing teaching. Brimonidine decrease aqueous humor production, just like timolol. Acetazolamide also, this is a has a diuretic effect, decreases aqueous humor production. Take note of the sulfa allergies for this one. Then for latanoprost, increases aqueous humor drainage. Okay, so only two possible actions. A drug will either decrease aqueous humor production or increase the drainage or flow of aqueous humor. Please take note of the side effects and patient teaching. Okay, so columns 3 and 4. Any questions about this chart or table? All right. So how long will the patient take this again? Okay, for life. The problem with this is remember what will happen when you put eye drops? What are the manifestations or side effects when you put eye drops? Remember we started with it on the first page. What will happen if you put anything into your eyeball? There will be tearing, blinking, right? So there's some itchiness. I mean, who has not received eye drops here? You've never had eye drops? Not even like Vicine, artificial tears? Okay. So for those who have, how do you feel whenever you receive eye drops? How does your eye feel?
Moist, like it refresh, like it
But immediately after administration, how did it feel? Did it feel refreshed, or was there
kind of like, oh, you were like,
was it irritating?
it did
Irritate, right? And then
it's like,
your tear, yeah, you start crying, right? Start tearing, and then very itchy, right? Sometimes itchy, yeah, a little red. Okay. Do you think those will disappear over time? No, because these are natural protections again in the eyeball. I mean, you read that on the first page, right? On the of chapter 58. So this will never go away. I mean, eventually you'll get used to it, but again, does it go away? No, because again, these are natural protections in our eye structure. That's just how we react again to protect our eyes, right, from any foreign substances. So that's the problem. It continues to be very um, inconvenient. And imagine if your patient is a child or a teenager. Will they be as cooperative as elderly people? Probably not. Okay, so that can be a challenge, right? If you're dealing with a tween, for instance, or a teenager, so it can be difficult for compliance. But the one thing you need to emphasize is this is done to what? Why are we giving eye drops forever? To prevent blindness. Okay, so if you expect to be, to continue to see, you have to comply with the eye drop administration forever. Surgery, again, I won't, but we will do pre and post-op. Let's do that next week. That will be under cataracts, because the only treatment for cataracts is surgery. Okay. All right. So let's continue next week.